Good morning. Thank you, Chegitan, for that, for the invite and the introduction. And I'm at the very outset, I would like to thank the AIOC and Dr. Chegitan for this opportunity. And today I stand as a counsel for Azathioprine as an immunosuppressive of choice. We know it's an antimetabolite. It inhibits the purine metabolism. And there are two enzymes which help in the metabolism of azathioprine, and that is TPMT and xanthine oxidase. And why do I say that it's a go-to immunosuppressive? Because of its effectiveness. It has a acceptable safety profile. We have a long-term experience. It has been in vogue since the 1960s when it was used for sympathetic ophthalmia, and obviously the cost. So let's see a few examples. This was a 12-year-old girl who came to me with complaints of decreased vision in her right eye. She had a sutured corneal open globe injury in the left eye, and she came with a granulomatospand uveitis in the right eye with cellularity in the anterior chamber and the vitreous cavity, disc edema, hyperemia, exudative retinal detachment, and an FA showing disc leak, pinpoint leaks with late pooling. So this was a sympathetic ophthalmia, and she was treated with intravenous methylprednisolone, oral steroids, and azathioprine, and it resolved. You may not be lucky all the time, but this was a 22-year-old male with a sympathetic ophthalmia, was on immunosuppressives, on Azaran, and he still developed an inflammatory CNVM, which was taken care of with intravitreal bevacizumab. So the main indication for any immunosuppressive per se is a non-infectious uveitis like a VKH, sympathetic ophthalmia, Behçet's, serpiginous choroiditis, and so on. This is one of my patients who had a granulomatospand uveitis, and you can see multiple pockets of SRF with fibrin septae, disc leak, pinpoint leaks with pooling. So this was a VKH, and it was treated with IVMP steroids and azathioprine. And you can see the resolution of the subretinal fluid following treatment. And this is a 6-month follow-up with a 612 N8 vision and a 624 N18 vision. Obviously did develop some subretinal fibrosis. Another VKH, an active stage, and with IVMP steroids and Azaran, he's resolving now. This was a 24-year-old lady with a decreased vision in the left eye, had a macular GHPC, and this is the resolved stage. She was also treated with intravenous methylprednisolone to start with, followed by oral steroids and azathioprine. A 29-year-old male with decreased vision and floaters, and we see there's an active retinal vasculitis in both the eyes, and with steroids and azathioprine is resolving. So other than the intraocular inflammation, corneal graft rejection is another indication of azathioprine. So most of the studies have shown a good effect of azathioprine following therapy, excepting just one study which was in the 1960s, which said that it is not effective. It has also been used for JIA-associated chronic anterior uveitis, either as a monotherapy or in combination with other immunosuppressives. And it was in vogue for Behçet's disease in the earlier stages, where it was shown to control the progression of the disease. So this is one of my patients, a 48-year-old male with retinal vasculitis, HLA-B51 positive or Behçet's, treated with steroids and azathioprine. It can also be used in special situations like pregnancy. So there is a case report of the use of azathioprine in the first trimester of pregnancy in a VKH. But to note here is if azathioprine is used with steroids, the chances of teratogenicity go up. It can be used as a steroid sparing agent or as a steroid equivalent as in VKH and SO. And it has helped us in reducing the maintenance corticosteroid dose from around 25 to 60 milligrams per day before initiation of azathioprine to around 5 to 10 milligrams per day in 6 months' time, with an 88% reduction in steroids at 6 months, an improvement in vision in 81%, and an improved inflammation score in 92% of the patient. It also helps in induction and maintenance of remission with a 90% remission within 1 to 6 months, and 88% of the patients did not have any recurrence during a follow-up of 1 year. Can be used alone or in combination, and there are various reports of triple-agent immunosuppression in serpiginous choroiditis and VKH. So a couple of pre-initiation checks before we start the patient on azathioprine. There has to be an absence of infection. You need to take a baseline counts and liver function test, TPMT levels, liaise with your internist, and dose according to the body weight. So TPMT actually inactivates the toxic product of azathioprine. Therefore, a patient who has a TPMT deficiency, the chances of side effects would be much more. So if the levels are less than 5 units, it is contraindicated. Whether if it is more than 19 units, it can be given in a normal dose. The dosage being around 1 to 3 milligram per kg per day. The most effective dose being 2 milligram per kg per day, and the expected duration of onset is around 1 to 3 months. It has also been used in lower doses as a steroid-sparing agent in VKH. So in this modern day of medical litigation, it is of utmost importance to take a written informed consent, and this is one of the consents which we have at our center. It does interact with other medications like allopurinol, causes severe leukopenia with ACE inhibitors, and can also inhibit the anticoagulant effect of warfarin. The side effects, common ones, are nausea, vomiting, diarrhea, the other ones being bone marrow suppression and hepatotoxicity. Fortunately, these are reversible. So this was a 27-year-old male with retinal vasculitis treated with steroids and was on azathioprine when his liver functions got deranged and we had to withhold azathioprine. Some anecdotal side effects of a disseminated tubercular granuloma, pancytopenia, severe cholestasis, alopecia totalis, and knuckle pad hyperpigmentation. They are clinical indicators of potential fatal complication because of pancytopenia secondary to azathioprine. Can cause infections like herpes or recurrent aseptic meningitis. As far as the risk of cancer is concerned, there are various studies which show that there's no significant increase in the risk of death or death from cancer if it is used for intraocular inflammation. The indications for withdrawal are a total count less than 3,500, platelets going below 1 lakh, hemoglobin less than 7 gram, and the liver enzymes getting deranged. If we compare it with other immunosuppressives, its side effects are almost similar to that of methotrexate. Mycophenolate might score over azathioprine as far as its side effect profile is concerned and the treatment success, but obviously one of the deterrents is a cost. When would we substitute azathioprine if there's an intolerance or if there's an inadequate response to treatment in 3 months? And there's a 100% consensus in conditions like Behçet's, sarcoid, sympathetic ophthalmia, GHPC, and retinal vasculitis. The cost used to be much more in the earlier days, around 1,000 rupees per month, vis-a-vis mycophenolate mofetil, which used to be around 8,000. But that gap has been bridged now, and there are cheaper brands which are available. So this would be somewhere around 500 rupees a month of azathioprine as compared to mycophenolate, 3,600. So azathioprine is still, could be the drug of choice, though in the earlier days that this was the only immunosuppressive available other than methotrexate. But nowadays, there are other immunosuppressives like mycophenolate available, and Dr. Chekitan would be covering methotrexate. And I thank you for a patient hearing.
It's a wonderful presentation. I'd just like to know, is there any retrospective or prospective comparative study between azathioprine with methotrexate or azathioprine with mycophenolate mofetil?
Not really. So with methotrexate and mycophenolate, there is. But azathioprine has not had, there's no head-to-head trial.
Yeah. And did you yourself have come across pancytopenia in your treatment?
No.
How often it?
Yes, but we have been very vigilant with the blood counts. So I get it done every month. And the moment there's an increase in, there's either a leukopenia or the platelet counts going down, we become very careful with the use of azathioprine, either reduce the dose or switch over to some other immunosuppressive. But I never have had a severe pancytopenia with azathioprine.
Do you do the TPMT anytime?
I had one patient who had a TPMT done, but I didn't do it. He had an Ehlers-Danlos, he had a Erdheim-Chester disease, and since his TPMT was, he was deficient, he was put on sirolimus. But TPMT is costly, it costs around 4,000 to 5,000. Yeah. But I think a prudent approach is to have a step-up approach to start with a lower dose, monitor the counts, and then increase the dose of the medication if the patient tolerates it.
Thank you.
What are your cutoffs, Amitabh, in blood counts, when you say when you should stop it or,
Yeah,
change
so
it?
if the total counts go down below 3,000 per millimeter cube, or the platelets going down below 1 lakh, or your liver enzymes becoming twice or more the baseline, that's when we would either reduce the dose, and if it goes up too high, say 4 to 5 times the liver enzymes, then probably we'd need to stop the medication and switch over to something else.
And also the tapering, I wanted to ask you, like if we have given 150 milligram, for a month, and then we slowly taper, and then 50 for maybe months together. So the big question is, when do you stop? That is the thing. And do you continue some patients only on azathioprine, or there is always a small dose of steroid? Because I usually, when I'm giving methotrexate, there's always a 2.5 milligram or a 5 mg steroid which is going on, and somehow I don't feel confident. Even if I go to 2.5 milligram alternate day, I don't feel like stopping it. And studies have proven that, the uveitis recurs if you keep it like only on methotrexate. So what's your take?
I think the dictum is to hit them early and hit them hard. So you start, if the patient is tolerating the medication, then you start at a full dose. The main aim of starting immunosuppressives is to try and either wean the patient off steroids altogether or to come to a minimal dose. In many of these patients, like a VKH, which is bound to be recurrent on SO, you may need to continue the immunosuppressives for a very long period. But I've had patients where I have totally stopped steroids and continued them on azathioprine for longer periods of time, say a couple of years in some of these patients. But
That would be 50 milligram? Or?
yeah, some of them have been on 25 milligrams per day. There's no rule of thumb of when to stop. You don't really know which is the end point of treatment. I think it's just trial and see how things go.
Most of the people feel that after 2 years, there's cessation of that disease. We can rather be safe in stopping the azathioprine.
Thank you so
Thank
much.
you.